Hey, everybody. Good to see. Well, I can't actually see you, but good morning or good evening. It's good to be with you. And Matthew, happy birthday. Matthew's Facebook page, I'm sure, is blowing up with happy birthday wishes.
Thank you, Teepa.
Because he's such a sweet young thing. He's just getting acknowledged by his family. No, everybody's saying something. Including his wife did this amazing thing. So Matthew, go ahead and share out that because that's really, I mean, she gets super credit. Check it out.
Ooh, yeah, and it's got multiple layers. That she has a Cricut. So it's this thing that cuts out paper material with these intricate designs, and it's multiple layers. I don't know how many. There's got to be at least 10, 15 layers here that stacked. But yeah, for my birthday. That's pretty cool.
That is super cool. That is super cool. Well, she obviously knows where you put a lot of time, effort, and energy, huh?
Yeah, that she does.
Being a peacock, no. Well, our phrase is, pack peacocks are more than just pretty. So we do stuff other than pretty. Our goal is not just pretty. So, we're starting the week off. I know we have some things happening this week. I don't want to forget that before I get into subject matter. We have Brain Connection Cafe this afternoon. We have guests tomorrow morning that are launching a song that they've put together with a video that will go out, I think, on Thursday, they said. And it's about reimagining dementia. And so this is an international group of like people more into the arts and into expression and going, you know what? Brain change is brain change. We all have brain change. So let's figure out how we could be together and do something really creative. And so they're doing a cool thing. And we're giving them some space to share that out. And then on Wednesday, we'll be back to our topic for the week. And then on Thursday, I believe we'll be back to the topic for the week. And on Friday, I believe, unless something comes up that I don't know about, which is always a possibility. And then Saturday, we're doing one where Rachel and I did a pre-recorded session based on questions that you guys had on Facebook or Instagram. So we're responding to 2 questions on Saturday, which is how do you help somebody fairly involved that can't do a lot of movements, has some restrictions in upper body, take a shirt off over their head, which can be really challenging when people start to have issues with mobility in their upper body. And you're trying to figure out how to, and it can feel like a battle or struggle. And then the other one is, what are some strategies to help somebody brush their teeth when they don't think they need help? Number one, they think they don't want any, how do you bring it up or how do you do something so you don't end up with a fight on your hands? And we at least try to address a couple of those. And we'll be doing that Saturday morning, just as an FYI. As far as we know, anyway, that's the plan for the week. You know how plans go. Ooh, and Matthew, did you get a chance to get the picture of the boys and the finishing the thing up?
I got the pictures, Teepa. The video, I was having trouble downloading. And so I'm hoping this morning, actually, I'm hoping I have better luck so that I can post those. And I'll post those on the thread for yesterday. So everybody who especially watches it in the future can see that. But if you want to see those videos of the marble
and we actually, to be honest, we actually finished it right after we had, as long as I didn't have to keep up with Matthew and you guys, then I could focus on the boys. And we did finish it right after that. And Dick took pictures and did the video, but trying to get it uploaded from our house, we have horrible speed. So it wasn't until last night Dick could do it when we went over to Amanda's. And then, Matthew's now having we'll see if we can figure that out. But anyway, that was our Sunday adventure with the boys. But it gives you a hint at when you know that you're trying to do one too many things for your brain, and you got to pay attention to those things so that what you're immediately involved with goes better. And that's sort of the theme for this week, which is care, whether you want to call yourself a caregiver, care partner, or a family member or a professional that's primarily partnering with somebody to try to figure out what the heck is going on here. We're going to go back to this idea of after the diagnosis. Okay, so you get a diagnosis. It is a dementia of some sort. Now, we've said before that actually isn't a diagnosis. It's a recognition of some symptoms that have a certain categorical consistency, which is it's at least a couple parts of the brain that are deteriorating, and It doesn't appear that right now we have any way to stop it or fix it or turn it around. And it's progressive. It keeps shifting. So it's not stable. It varies, but it varies dependent on more factors than just the dementia. It varies on the type of dementia, but it also varies on other health conditions, environmental elements, the people around, the opportunities, how people are using their time. But ultimately, it is a terminal illness. But to focus on it being a terminal illness, if you've identified the symptoms really, really early, doesn't make a lot of sense, other than you do want to acknowledge, well, there is an endpoint here, and I'll need to learn about that as we move forward from a care partner perspective.
Ooh, Teepa.
Yeah.
So I was curious. We've used the terms illness, disease, and syndrome.
Yeah.
So real quick, could you touch on, is there a difference between those?
Yeah.
If somebody goes into a doctor's office and they hear a doctor say, this is an illness, or this is a disease, or this is a syndrome, what could help them understand if there's a difference on those or what that means?
Yeah, so that's a lot of medical jargon, if you would. And so a syndrome is sort of like, okay, so it has this characteristic, and this characteristic. Now, what has that characteristic? The things that people are identifying as not normal. So when I start picking up on things like people cannot hold on to things that just happened with the same clarity that they used to be able to do. People cannot find their way to and from locations as easily and readily as they used to. They get lost. People are having difficulty coming up with the things that you say, words, or they may even use weird words, or they can't seem to understand what you're asking them exactly, even though they get it, but they're just being, at first you think maybe stubborn, but no. They're having, so what we start doing is collecting what we identify as not normal. And again, in dementia, for them. Okay. Now, when you have a certain illness, like a urinary tract infection, there are indicators that are very distinct. And so, for an instance, with a urinary tract infection, we're looking for bacteria. We're looking for bacteria in your urine, and we're looking for a certain level of bacteria. We also look for white blood cell count. We look at things that indicate infection. And we look at it in the urine because we suspect that there is a problem in that area. Now, some of the symptoms that brought you in might be burning, itching, frequency, foul smelling, so those are symptoms that lead us to identify the condition, which is called an illness. In this case, a urinary tract infection. Now, what's cool about that is once I get that, then I, as a provider, whether, a medical provider, you go to the medical provider to do that. What do I want? I want a fix for it. But we're realizing with even UTIs, which is an illness, it's a condition, and it's specific, we've got to be careful about the quick fix, about the antibiotic for that bacteria, because if there's a pattern to this, then what the person may have is a syndrome, a condition, and perhaps what's causing the UTI is not just the bacteria. There's something else causing that to reoccur. And if we just keep giving antibiotics every time it pops up, what happens is the bacteria that survive get stronger and stronger and stronger. And pretty soon the antibiotics we would normally use don't work. And then we have to go to other antibiotics. And then we have to go to really powerful antibiotics that have impact on the rest of the system in a negative way. And then sometimes we can't even find an antibiotic that will treat it. So what we have to go back to is what caused the problem. And the problem was your immune system is not great. And maybe you're not cleaning yourself in a way that is helpful, or maybe you're not drinking enough. So now we start coming up with strategies to manage the risks of having a UTI repeatedly. But we don't worry about it if you just have it once in a great while. We give you an antibiotic and be on your way, particularly if we got a certain level of things. So the problem with any dementia is it's a umbrella term that covers like probably well over 120 some conditions. Some of them have similarities, some are very different, but at least we know that if you have that, at least two parts of your brain are having problems, that it's nothing we can fix as of right now, and it's progressive. And ultimately, prognosis, if nothing else happens first, you will actually die due to the changes in your brain that can't keep your body running. But there are lots of ways you could have problems well before that, and you never get to the end of dementia. So this idea of really recognizing after the identification of the category of condition you have, the illness that you have. Now, is it an illness or is it a condition? The illness would be like with the UTI. Having a UTI is an illness, but finding out what's driving you to get the UTIs, if you have them at one after the other, is sort of the condition that leads to the medical situation or the problem situation. The thing is, that's where we're sort of in dementia, we're still discovering all the different sorts of brain change, brain deterioration that we could be looking at, and we still are just learning about what's causing it. And we're getting closer to believing that a lot of brain changes are caused by viruses crossing the blood-brain barrier and setting up housekeeping and doing damage. And our brain's not cleaning as well. And so it has to do with an immune system problem. Oh, bummer. But other times it may have to do with a blood flow and nourishment problem, or it could be some combo. This is a lot trickier than we want it to be. But so here's where, when we get focused in on the condition or the illness, we start micromanaging things, thinking, okay, well, then I'll do this and I'll do this and I'll do this, and this will make it all better. And it's like, as a care partner, whoa, just like the physician, we have a tendency to want to do a quick fix. We want this fixed for the person and for us, and we want it to go well. We want it to not be a problem. So I'm going to go back to the slide I showed before, Matthew, the one, but I have modified it to fit this situation. So did I give you enough jibble jabble to answer the question?
Yeah, that was good, Teepa, because I know for a lot of folks out there, especially that are just getting into this, they hear a whole lot of terms. And again, I'm guilty of this as a healthcare professional. There's been times I've thrown out a lot of medical jargon, and I've seen that look on family members' face, like, what did you just say? On top of the news that you're giving, on top of the subject that you're talking about. So this idea of at least starting to pick up on, okay, so what are the differences on some of these? Because some of them sound the same, or they seem like they're being used in the same way, but I'm not sure. So yeah, that was very helpful. Thank you, Teepa.
Yeah, no, good. So our topics this week and what we're going to focus on after today, other than our special guest tomorrow, is that we're going to focus on what do you do next when somebody has dementia and you're trying to be supportive. Okay, so you're the care partner, caregiver, you're the other involved, and you want to support them. So let's back up and notice why we came in. Why did we come into this situation to go to the medical provider and get this information in the first place? What is it we were looking for? So here's why we go see the provider. A health concern really not related to dementia came up, and we got somebody in because we were worried about this other health condition. And they pull us in and say, I think what you got going on here is a dementia. And that's probably why this diabetes is so out of control. Or, that's, I think, why you're seeing this, or this. And it's like, what? No, I mean, we came in because, she was complaining about headaches. Yeah, I got you. But that's the least of your problems. I can give her something for the headaches, but this is something else. And it's like, whoa, blindsided. Oh, wait, what? The second one is that we go in because we think there's an emotional issue going on here. We think it's depression or anxiety. I could also add in here, we think it's a vision problem, or we think it's a hearing problem, or a mobility problem. But, we think it's one of those. So we're going into it with a certain mindset that we think we know what the issue is, what's causing the symptoms. And we again get, boom, blindsided. Because it's like, but what? No, she has anxiety. That's why I have her here. She has anxiety. So again, the third reason we might be the one who's going into the doctor's or provider's office with somebody. And the reason I say that is it's not uncommon for people to see a nurse practitioner or a physician extender in these, or might even be a nurse somewhere or a social worker that you're running across. Could be a provider of a rehab service, because Matthew might be seeing somebody for balance issues and then going, whoa, I think we have something else going on here. Or as an OT or a speech therapist. So the third one is I just got involved and I think something's not right and I want it looked into, but I certainly don't want it to be dementia. And I may not be thinking dementia at all. I'm thinking that this will be a fixable. So I'm walking into it thinking, yeah, so what's going on here? I mean, something just doesn't seem right. But it's not on my radar, or I don't want it to be dementia. So there's a real pushback for hearing that it's dementia. I really don't want it to be that. Mom had it, whatever it might be. I have a mindset. I don't want that. I've been involved and I finally talked the person into getting to see you as a medical provider. And it's like, but I really don't want to hear it's dementia. I don't want to hear that. And those are probably the most common things. People don't want it to be dementia, even though if you've been involved and you're thinking, something's going on here, and I finally talked to the person, and I might at some level have awareness, but I do not want it to be dementia. So the other thing is that the other person, the person who has it, is the one that thinks something's going on. And they don't want it to be dementia, and neither do I. I may not even think it is dementia. I think they're just overreacting. They've been under a lot of stress lately. I may not be the one that's aware. Or finally, I've been involved. I want to know what type of dementia they're living with. I mean, or that I'm working with. I get that it's dementia. I'm looking for something more. I actually come into this as a fairly knowledgeable person, and I'm looking for some details to help. So I'm going to pause there for a second. Matthew, what does that say about us? What are you thinking? I mean, do you think we need to be aware of what we're coming into this with as supporters?
Yeah, Teepa, and you keep bringing this piece up, which is huge. I mean, nobody goes in there. It's a rarity that someone goes in expecting a diagnosis of dementia, and so
we're wanting it anyway. We're wanting to hear that.
Yeah. Let's face it, nobody wants to get a diagnosis.
He's looking like, oh, good. That's what I was sure hoping that's what it was.
No.
Man, that is great news. I really thought it was schizophrenia. It is super to hear it's just dementia.
Yeah. No.
I mean, nobody comes into a doctor's office thinking, oh, God, I hope it's just dementia. I mean, that's what we're thinking.
No. Yeah. And when you get that news, especially when you think it's just something that is probably simple and all the doctor has to do is just get him a medication and then this is going to be fixed. But when that comes, yeah. And so this idea of, at least picking up on as much as you can, what's going on, because that can really help too. Because a lot of folks who think something is happening in that direction, sometimes their frustration is they're hoping the doctor will really look into it and really get a good idea and give them something or an explanation of why this is happening.
Okay, so Matthew is doing a great job of my next slide. So I thought I'll throw it up there and see how many he hasn't said yet that he should, because he actually is right on the money with what it is. So why did I come in here for medical support? And it's like, well, it might be to get a diagnosis, and actually what we're looking for is a prognosis. So how much, so what can I mean, what's going on here? How much longer do they have? I mean, how fast is this going to progress? What's going to happen next? So we often go in wanting to know, how is this condition going to change over time? How long, how deep, how fast, what comes next? Sometimes we go in wanting to not have dementia and want it to be something fixable, which is what Matthew was just describing. And then sometimes we go in, we know it's dementia, but we want him to fix it. Surely there's something out there. Surely tell us what the latest, surely there's something that can be done. Sometimes we go in because we want the symptoms fixed. I mean, we really just don't want to see these symptoms of what's going on. So whether you can fix the dementia or not, I want this thing to not be happening anymore for them. Isn't there something we can do about her getting lost? I don't want her to get lost anymore. I don't want her to ask me the same questions anymore. I don't want him to be risky with his money. I don't want him putting money on things that he's spending weight. And it could actually be the symptoms that we're describing are problem situations. And most of us would describe them at that point anyway, when we're first getting started, as problem behaviors on the part of the other person. But what we're really describing are symptoms of dementia that are making it difficult for us to figure out how to do support. And then some of us go in wanting help, how to make it, whatever it is, better. We're going in there thinking, I need help to make this better. And sometimes the reason we're going in is I want the person to tell me or us, me and the person, where I or we should go next. I'm thinking they're a professional. They should know what I should do next because I'm not sure what to do. So I'm going to pause there, Matthew. So how does that sound? Was that pretty much, yeah?
Yeah, that was perfect, Teepa. I mean, and thinking about, again, this idea of, someone actually brought this up, it's amazing or surprising sometimes why more families don't go researching different types of dementia, look into that. But it's this idea though of how tough is that? I mean, to go look at something like dementia with your and thinking about your family member at the same time, is that something you're going to want to go look into, or you're going to want to do this and hope that it's not that, and hope again it's that simple fix?
Yeah. And I think the other thing is the medical profession, and we already talked about this last week, uses the word dementia and specific dementias sometimes interchangeably or inaccurately. They use words like treatments for things inaccurately. So the most non-helpful things, and this is where we're going to pause after this today, is, so what are some of the most non-helpful things that happen that we could do after the diagnosis? So people let me think that the meds that help with symptoms are actually changing the dementia. So I believe, from what I've heard, that it is essential that we get these meds in because they're actually changing the dementia. And I believe that this is my only shot at helping you, is this med. So I start to believe that, and that it becomes an agenda item. We've got to do it. And I'm not really listening for or paying attention to possible side effects, or that it might not make a difference. And it's not actually changing the dementia. It might be changing some aspects of brain function, but I won't know if I don't know to look for that. But if nobody's told me that, and I think I'm doing one thing, then I can really become adamant about it rather than helpful. So one of the things that people do that's not helpful is talking too much or not at all to just either one of us or neither of us. So when health providers talk too much, and then I might, or my person, or they don't say anything at all. They just say, we'll see you again in about 3 months, maybe. Let me know how things are going at that point. Try that. And it's like, wait, what? Or they keep going, and we're not processing at this point, either of us, or at least one of us, or maybe they're only talking to one of us, and that's not helpful. then this recommendation to get your affairs in order and select a durable healthcare power of attorney. There's an assumption that I even know what a healthcare power of attorney is, and that get your affairs in order. What do you mean? I mean, people make statements like this. You really need to get your affairs. You need to get, you'll need to get a healthcare power of attorney for sure. And it's like, do you know how hard it was to get her into the doctor's office? I don't think you understand. So, when we get these recommendations and we try maybe immediately to act on the recommendation, it can be so non-helpful because we're focused again on an agenda item that somebody's given us. So we get focused on agenda. This is also not helpful when I hear these words. There is nothing that can be done, because I just got this, I got slammed with this word dementia, or maybe I got something more, but nothing can be done. Well, you got to be kidding me. I mean, there's got to be something. And then giving up on us in general, saying, well, I don't really need to see you. You can go back to your regular provider, or you'll want to get up with whoever usually does. So this idea of I've come to try to do something, and you're basically telling me, well, get up, you can talk with my nurse next time, because once we've identified this, unless there's something new that happens. Now, if her diabetes gets out of control, or asking me or us to do something while not addressing the real issue. And this one is a kicker. So sometimes I'm like, well, so you need to get her to stop driving. You'll need to have her not be going to work. I mean, she's at real risk for making mistakes, or you need to get her to take these medications or exercise. I mean, this would make such a big difference for her. It's like suddenly asking me to be the controller of this person when we didn't really even have a conversation of any depth. So handing the reins of her condition, her syndrome, over to me and saying, here you go, I've done my part. And it's like, whoa. So this is where we're going to pause. Matthew, I bet our lines are burning up out there.
Yeah, we have a lot of folks throwing in some great comments about this, and again, it's a challenge. You could think of many names of this particular situation, especially in the beginning, right off the bat, and so all of the different pieces that go into that. And I know as we get into these things, like I started to jump into that next slide with what I was saying, we'll touch on a lot of these pieces, but yeah, a lot of folks definitely piquing interest and sharing out of situations or.
Yeah. I mean, it's one of the biggest stumbling blocks to having a journey that makes sense for both of us is not exactly getting things organized in our own brains, in our own lives, in our own minds before we start going somewhere else. And this is the care partner role, but it happened with the medical provider. It'll happen with the care person, the support person, the person who's supposed to be there for support, and the person living with. I mean, all three of us get slammed with information, and there's not really a good, okay, let's pause. Let's see what each person thought they said and what you thought you heard. And let's take stock and let's figure out next steps. And the very next step is figuring out, that's tomorrow, or actually Wednesday. We're going to leave you with a cliffhanger. Because people have the stories of what happened next for them, and we all have them. But what we're going to talk about is what would best practice maybe look like? And remember, we got a lot of different people coming into the mix. So there's not going to be one answer fits all cases. And I think that's the big message here is we've got to look at each individual situation and figure out, why did people come here? Where are they with each other? How far along in their condition is this person? And what even type of condition do they have? How is it impacting their life? Where is it not impacting their life? What kind of skills do they have left? What can we work with? What are their resources? I mean, in and of itself, realizing that dementia is one of the most complex syndromes you could live with. And we aren't doing a good job of identifying what sort of dementia. And so what kinds of options might be our best options for and I'm going to use the word, long haul. And our friend Curry would tell you long haul trucking is hard work, but it's satisfying in many ways once you get the rhythm of it down. But there are certain routes you want to travel, and there's certain ones you want to avoid. And that's what this journey is going to be about. Because sometimes there are detours, sometimes there's, disasters you didn't know about. But anyway, all right, Matthew. Well, it is time for us to sign off so you can go celebrate your birthday. Actually, I think you're getting a lot of stuff done that you need to get
I keep putting off, and I'm like, okay, if I'm gonna have
another year older, it's time to buckle down and get her done.
That's right. Get some stuff done.
Get her done. All right. Well, we will see everybody tomorrow morning to launch a song about celebrating, the possibilities and the options that we have. And then we'll be back to work on Wednesday. And if you're bored and you're looking for something to do, come and join us for our Brain Connection Cafe this afternoon. We'll have some fun. For some of us, at least, it'll be a challenge for your brain and a chance to get around people virtually in a safe way that might be kind of interesting. So till next time, take care all.
Bye, everybody.